The following podcast is part of a certified educational activity titled Up Close and Personalizing Gastric Cancer Care, Precision Medicine with HER2-Targeted Therapies and Other Novel Agents. Access the entire activity and complete the post-test at peerview.com/JQB860. Downloadable slides and practice aids are also available.
Welcome to Up Close and Personalizing Gastric Cancer Care, Precision Medicine with HER2-Targeted Therapies and Other Novel Agents. I'm Dr. David Ilsen from Memorial Sloan Kettering Cancer Center, and I'm joined by my colleagues Dr. Laura H. Tang, a pathologist, and Jeffrey Koo, a medical oncologist like myself. During this activity, we'll review the latest efficacy and safety evidence and provide practical guidance on the role and use of current and emerging personalized therapies for advanced gastric cancer. This is our agenda today. Dr. Tang is going to talk about the latest advances in HER2 and other biomarker testing to help guide therapy selection. Dr. Koo will review the evolving standards of care with novel HER2-targeted agents for HER2-positive gastric cancer. And I'll close the session talking about how we integrate and evaluate some of the new and emerging treatments for advanced gastric cancer. Gastric adenocarcinoma is the third leading cause of cancer-related death globally. As we can see from the slide, there's wide geographic variation. In North America, this is a relatively uncommon cause of cancer, but 50% of cases occur in developing countries, and by far the lead incidence areas are Eastern Asia, Eastern Europe, and South America. In the United States, we'll see approximately 27,600 new diagnoses and 11,000 deaths annually in the United States. In the setting of metastatic disease, there's a relatively poor prognosis, with median overall survival less than 1 year. I'm now going to turn the podium over to Dr. Tang.
Hello, thank you, Dr. Ilsen. The treatment options for gastric cancer have been limited for many years with a few conventional chemotherapy regimen and with a less than satisfactory response. Until 10 years ago, HER2 became a potential target in selected patients. 6 years ago, the TCGA effort led to the molecular classification of gastric cancer into 4 different subtypes. About half of the cases of gastric cancer were considered as chromosomal unstable, with associated many gene mutations and chromosomal alterations. About 20% cases are genomically stable. These are usually signaling cell morphology, with less gene mutations and alterations. Interestingly, 22% patients cases are associated with DNA mismatch instability, and a small fraction of the tumors are associated with HIV infection. So these molecular subtypes are associated with some potentially targetable phenotypes. EBV infection and MSI subtypes are associated with PD-L1 and PD-L2 overexpression. In addition, MSI subtype is also associated with HER3 mutation or amplification or chromosomal alteration. HER2 expression or amplification is highest in the genomic unstable subtype. Unfortunately, there are very few targetable genes in the genomic stable subtype. The molecular phenotype can be translated into a number of targetable therapies for gastric cancers. As mentioned earlier, HER2 is a predominant target for genomically unstable subtype, although other potential targets have failed in clinical trials. MSI high cases as well as EBV infected cases can be treated with immune checkpoint inhibitors. And very few targetable therapies are available at the moment for genomically stable cases. Based on these findings, several biomarkers can be tested as an initial screen for candidate patients with gastric adenocarcinoma. Here are some examples showing diffuse HER2 expression by immunohistochemistry in gastric adenocarcinoma. And one of the DNA mismatch repair protein is lost in gastric cancer. And PD-L1 expression can be seen in both cancer cells as well as immune cells. And EBV can be detected by in situ hybridization. I would like to spend a little bit more time on HER2 since this is a better established marker. Overexpression and amplification of HER2 really depends on histological subtype, with intestinal type being the highest and diffuse signaling cell being the lowest. In addition, better differentiated tumors have a higher expression of HER2 than the poorly differentiated tumors. Compared to breast, there are several issues should be mentioned. First of all, the heterogeneity of immunostaining is much higher in gastric adenocarcinoma. Because of this heterogeneity, the possibility of false negative testing is much higher. In fact, if less than 6 biopsy small samples were tested, the false negativity rate can reach as high as 9%. Another major difference is HER2 expression in the digestive system lack the luminal membrane staining, so the staining pattern is not that of a circumferential pattern. Instead, it is a basolateral or lateral pattern. These differences underscore the importance of using gastric or gastroesophageal specific criteria to assess HER2 expression in clinical practice. Here is an example showing heterogeneity of HER2 expression in a gastric adenocarcinoma. In this small biopsy, one can see any area anywhere between HER2 negative to unequivocal to strongly positive. So if a small biopsy is taken from a different area, one can imagine the false positivity in this specimen. HER2 expression by immunohistochemistry is scored as 0, 1+, 2+, and 3+, with 0 and 1+ being negative, and 3+ as positive, and 2+ being equivocal. This is based on both the quantity and the quality of the staining pattern. Positive staining 3+ requires strong intensity as well as complete or basolateral or lateral membranous staining pattern in more than 10% tumor cells in a surgical specimen. The same staining pattern and intensity are required for small biopsies or cytology specimens, but it only requires a cluster of more than 5 tumor cells. Negative results, 0 and 1+, have either no or very weak membranous staining or in less than 10% tumor cells. Equivocal results, 2+, indicates adequate quantity of expression of HER2 in more than 10% cells, but with very weak or moderate staining intensity. Here are some examples of HER2 immunoreactivity with negative results. HER2-0, meaning no membranous staining, although there is some cytoplasmic staining, which does not count. 1+ in the other two examples has very weak staining without complete or basolateral staining pattern. HER2 equivocal 2+ showing some moderate intensity, but appears to be less than 10% tumor cells. And finally, HER2 positivity showing either complete circumferential membranous staining on the right or very strong basolateral membranous staining pattern. When HER2 is equivocal 2+, FISH in situ hybridization for HER2 should be performed. In situ hybridization can be performed with multiple methods, either a single HER2 probe with greater than 6 signals being positive, or HER2 and chromosome 17 centromere, 2 probes. The ratio of the two should be greater than 2 to be interpreted as positive. There are rare situations one may have a ratio of HER2 and centromere 17 less than 2, but the HER2 copy number is greater than 6. That's also considered being positive. And here are some examples of HER2 negative and positive. In the negative examples, not amplified, you can see in the first left, the number of HER2 and the centromere 17, the ratio is exactly the same. In the middle example, although the signals, there are more signals for both HER2 and the centromere 17, the ratio of the two is still less than 2. And finally, you see the red signal being HER2, which is much more than the green signal of centromere 17. So this is considered a ratio of greater than 2 and being amplified. HER2 status can be also assessed on next generation sequencing platform, although this is a byproduct for genetic testing of hundreds of other genes. The advantage is HER2 can be assessed both by copy number as well as a mutation status, and it can work on multiple different kinds of specimens, including fine needle aspiration cell blocks. And here is an example showing on the top right, above the chromosome 17, an amplification of HER2 signal, which is associated with HER2 expression by immunohistochemistry, as well as confirmation with FISH. A few words on DNA mismatch repair protein and microsatellite instability testing. There are 2 kinds of tests. For mismatch proteins, we test 4 different proteins: MSH2, MSH6, PMS2, and MLH1. So in normal cells, all 4 proteins should be present, which is considered stable, retained. Loss of nuclear staining of any one of these proteins is considered as MMR deficient. The other test is microsatellite instability by PCR, which can be interpreted as stable, or MSI low, which shows mismatch unstable in less than 30% of the markers, or one of the 5 markers. MSI high indicates greater than 30% of markers exhibit instability, or 2 of 5 markers shows instability. And finally, PD-L1 testing in gastric cancer. And this is FDA-approved companion diagnostic test for surgical specimens in paraffin-fixed and formalin-embedded tissue. And there are a number of antibodies available. And unlike PD-L1 testing in other cancers, in gastric cancers, we have a specific interpretation, which is called the combined positive score, which expressed as number of PD-L1 positive cells, including tumor cells, lymphocytes, and macrophages, over the total number of viable tumor cells. And you see an example of negative staining in both tumor cells and the lymphocytes, and the example of very positive staining on the right, showing expression in both tumor cells and the inflammatory cells. So the way to report PD-L1 test, one has to include the antibody being used. In addition to CPS score, we also report the relative contribution of tumor cells as well as inflammatory cells.
Okay, Dr. Tang, thanks for that excellent overview of pathologic and testing issues. It looks like we have some questions from the viewers coming in. I think this is a very timely question, and we can address this to the whole panel. Do you order repeat testing on these biomarkers every time a patient switches therapy? Maybe Dr. Ku, you can address that.
Yeah, I mean, that's definitely a great question. So I think, with regards to the three relevant biomarkers, so HER2, PD-L1, and MMR, certainly, in a patient who's progressing from one line of treatment to another, I typically don't rebiopsy a progressive lesion. The sole exception is for tumors that are HER2 positive. So certainly there are now data sets suggesting that up to 1/3 of HER2 positive tumors become HER2 negative at the time of progression on trastuzumab-based therapy, and that's a mechanism of resistance. So, I think our institutional standard is to biopsy those patients. If we confirm that the tumor remains HER2 positive, we certainly have numerous HER2 positive studies we would focus on. If not, we would focus on either standard of care or options or other experimental options for HER2 negative. PD-L1, I think MMR, I think, there really are no data that, for example, an MMR proficient tumor would suddenly become MMR deficient or MSI. So I don't think we would biopsy for that reason. PD-L1 is a little bit tricky. I think there are emerging data sets that there's both spatial as well as temporal heterogeneity with regards to PD-L1. So certainly if a tumor is initially PD-L1 positive and qualifies a patient for subsequent use of immune checkpoint inhibition, I would not repeat it. But on occasion with PD-L1 negative tumors, particularly if the patient is having a procedure anyway, we would retest to see whether a PD-L1 negative tumor is now PD-L1 positive. But certainly I would be interested to hear your opinion and Laura's opinion as well.
Yeah, I think outside of a study, because we know, we'll talk about this later during the discussion, but once a patient progresses on trastuzumab, there really isn't a standard option to target HER2 after that. We'll talk about that later. And we know that continuing trastuzumab into second-line therapy probably isn't helpful. And the PD-L1 question is interesting because we also, a positive is accepted at 1%. Maybe Laura, you can comment on our reflex testing at our institution, which we test routinely now, all of these markers in patients when we get initial pathology.
Yes, correct. We are testing them, all three, HER2, PD-L1, and MMR, by immunohistochemistry as the initial screen. This is routine. We also do EBV as well, although it is a small fraction of cases, but since there's a significant indication for treatment, so we do them routinely now.
Yeah, I think now potentially with the availability of more later line active therapies, it certainly is a consideration to retest, but also there are other resistance mechanisms that we may not be able to impact on even if we detect them. So I think let's continue with the next part of our program. Dr. Ku is now going to review evolving standards of care with novel HER2-targeted agents for HER2-positive gastric cancer.
Great. Thank you very much, David. And Laura, thank you for that great presentation. It actually was very helpful to see side by side, what an IHC 0, 1 plus, and 3 plus tumor is. So, I'll take over and now talk about the standard of care with regards to HER2 therapy, as well as a number of promising emerging novel therapies. So I think, many are familiar with this particular Kaplan-Meier curve. This is from the pivotal TOGA study that was first published in 2010. And that was the first study, that was the first study that established the benefit for adding trastuzumab to chemotherapy in the first-line setting. Having said that, this particular Kaplan-Meier curve is actually from an exploratory analysis, and specifically, it focuses on outcomes in patients who are HER2 positive as we would define it currently. So specifically IHC 3 plus or IHC 2 plus, but FISH positive. You'll recall that the original study also enrolled patients who were FISH positive, but IHC 0 or 1 plus. So if you look at this Kaplan-Meier curve, you'll see indeed that in this particular group of patients, there does appear to be greater benefit for adding trastuzumab to chemotherapy. Specifically, the median overall survival is 16 months, which exceeds the 13-month number that was seen in the overall intention to treat population. This concept is represented here in the forest plot, and in particular, if you look at the red oval at the bottom, you'll see in a post-hoc exploratory analysis that the totality of the benefit for adding trastuzumab to chemotherapy does seem to be confined to patients who are either IHC, or whose tumors are either IHC 3 plus or 2 plus and FISH positive, and in the smaller number of patients who were FISH positive but IHC 0 to 1 plus, there didn't seem to be as much benefit. So that really leads to this particular treatment schema or paradigm, which is the current treatment paradigm. I won't belabor the point, but HER2 testing should be done sequentially, initially with IHC, and FISH should be performed only on tumors that are IHC 2 plus to try to distinguish whether they are FISH positive or FISH negative, and therefore ultimately HER2 positive or negative. Of course, adding trastuzumab to chemotherapy is standard for a HER2 positive tumor. I won't focus on this too much or on the later line therapy, since I know that Dr. Ilsen will be discussing it later on in his talk. So this then is the history in one slide of subsequent phase 3 studies that were done evaluating HER2 therapies. And after the positive results of TOGA, it really seemed like we were caught initially in an endless loop of negative studies. In fact, the only study that came closest to being positive is the first one, and that's the JACOB study. And that was a study that added pertuzumab to the now standard combination of chemotherapy and trastuzumab. Pertuzumab is a monoclonal antibody that binds to HER2 at a different epitope than trastuzumab, and its binding prevents HER2 from dimerizing with HER1, also known as EGFR, and with HER3. So the study I would consider a near miss. You'll see that there is a 3-month improvement in overall survival numerically, but unfortunately this did not reach statistical significance, but the p-value was close. It was 0.056. The hazard ratio was 0.84. Response rate and progression-free survival actually were significantly improved. So I do think that if the study had enrolled a slightly larger number of patients, we potentially would have had a second FDA approval by now, but ultimately this was a negative study. The next study is the Heloise study, which is an interesting premise, and it was based on the observation that for unclear reasons in gastric cancer, levels of trastuzumab in the blood and at PK are lower than, for example, in breast cancer. It's been postulated that there is a higher tumor burden in gastric cancer, and therefore the tumors act as a sink and draw up all the trastuzumab. So this study evaluated the idea of a higher dose of trastuzumab in addition to the standard dose, but was also negative. There are then 2 studies that evaluated lapatinib, which is a TKI against HER2. The first study was LOGIC, which is in the first-line setting. That was negative. The other study was a second-line study called TITAN, which added lapatinib to paclitaxel, and also showed no benefit for this approach. I would add that potentially one of the reasons why these were ultimately negative is that HER2 positivity was defined by FISH alone. So it's conceivable that some proportion of tumors were FISH positive, but IHC 0 or 1 plus, and may have derived less benefit from the addition of lapatinib. The other second-line study that's notable is the Gatsby study. This is a study that compared single-agent paclitaxel with TDM1, and this is an antibody-drug conjugate The chemotherapy component is a microtubule inhibitor. This also was a negative study. The one other thing I would mention about most second-line studies is that they didn't mandate pre-treatment biopsies. And as we mentioned a little bit ago, there are now data that up to 30% of tumors that are HER2 positive subsequently become HER2 negative when they progress on first-line trastuzumab-based chemotherapy. So it's also conceivable that part of the reason why these studies failed is that essentially patients were being offered anti-HER2 therapy when their tumors were now HER2 negative. An important negative study that absolutely bears mentioning is the results of the RTOG-1010 study. This was presented as an oral abstract recently by Howard Safran at ASCO. So this is a study that evaluated the addition of trastuzumab to standard chemoradiation with carboplatin paclitaxel followed by surgery in esophageal and GE junction adenocarcinomas that are HER2 positive. The results, certainly in my perspective, were unexpected and disappointing, but really suggested no benefit from adding trastuzumab to standard of care. You see that the DFS curves as well as the overall survival curves absolutely are superimposed. And similarly, there was no improvement in pathologic complete response rates. It's certainly unclear why trastuzumab is unsuccessful in this context, and it's hoped that some of the biomarker analyses may shed some light potentially on intrinsic markers of resistance to anti-HER2 therapy. Moving on, there are fortunately new HER2-directed therapies, many of which are promising. In fact, one will likely receive regulatory approval in the US, but also in Asia. And that is trastuzumab deruxtecan, which I'll talk about. There are novel monoclonal antibodies, margetuximab. There's a new bispecific antibody, ZW25. And essentially, all of these approaches are being combined with immune checkpoint inhibitors, several in phase 3 studies. So trastuzumab deruxtecan, or DX821A, is a novel antibody-drug conjugate, and it has a slightly different mechanism of action than, say, for example, TDM1. So specifically, it employs a different payload. The payload is a derivative of exatecan, which is a topoisomerase inhibitor. This is a very potent chemotherapy drug in and of itself. And in addition, there is a very high ratio of drug to antibody. There are between 6 to 8 molecules of chemotherapy per molecule of trastuzumab, and that's double the ratio or density with TDM1, for example. Very importantly, it's thought that this drug has a bystander effect, meaning that the chemotherapy payload is able to kill not only the HER2 positive cells, but other cells around it. And this is critically important in a disease such as esophageal gastric cancer. So as Laura mentioned, there's significant heterogeneity in HER2 expression and staining in gastric cancer. It's certainly not as uniform as in breast cancer. And here we see in the control HER2 positive cells surrounded by HER2 negative cells. When treated with TDM1, the HER2 positive cells are eliminated, but the HER2 negative cells persist. But because of this bystander effect, trastuzumab deruxtecan can affect both HER2 positive as well as the surrounding HER2 negative cells, and that likely translates into increased anti-cancer benefit. So this drug was initially evaluated in a phase 1 dose escalation and subsequently dose expansion strategy. And ultimately, patients with esophageal gastric cancer were treated at 2 doses, 5.4 milligrams per kilogram, as well as 6.4 milligrams per kilogram. These are data that were presented by Kohei Shitara of these patients. Ultimately, 44 patients received one of these 2 doses. Again, these were all patients who had progressed on trastuzumab, as well as several other lines of treatment, so were heavily pretreated. So in this context, the response rate was very impressive. It was 43%. At the same time, the duration of response was also notable. The median length was 7 months. And ultimately, in a heavily pretreated population, the median overall survival was almost 13 months, which is indeed very, very impressive. The toxicities of the drug are consistent with that of its chemotherapy backbone, so that myelosuppression are the main toxicities. But in the phase 1 study, and certainly even in this dose expansion, a small proportion of patients were noted to have developed pneumonitis. This was initially surprising since neither trastuzumab nor topoisomerase inhibitors are known to cause pneumonitis, but certainly it was a toxicity that was noted even early on. So these very promising results led to a randomized phase 2 study, which is the Destiny Gastric 01 study. So this is a study that was performed exclusively in East Asia. And the main comparison was to randomize patients to trastuzumab deruxtecan versus dealer's choice of either irinotecan or paclitaxel as third-line therapy. You'll note that there were 2 exploratory arms as well, and those involved treating a small number of patients with what we would consider to be HER2-negative tumors at this point. One group of patients had tumors that were IHC2+, but FISH negative, and then the other group had tumors that were IHC1+. Again, this is based on the premise that because of the bystander effect, it may be possible to treat tumors that are marginally HER2 positive and still derive benefit. So at this time, only the results for the randomized comparison, so the box up top has been presented. In fact, this was presented as at ASCO as well as a virtual oral presentation with simultaneous publication in the New England Journal of Medicine, again by Dr. Shitara. So these are the results of the randomized portion of the study, and you'll actually see that the confirmed response rate was exactly what was seen in the phase 1b study with a 43% response rate. On the right, you see the waterfall plot with outcomes for patients treated with trastuzumab deruxtecan in the blue bars, and you'll note that there was a significant proportion of patients who actually achieved a complete response. So the primary endpoint of the study was actually response rate, but if the response rate endpoint was met, they would then look at secondary endpoints, including progression-free survival and overall survival. And you'll see here that there was also clear improvement in PFS for trastuzumab deruxtecan over physician choice of chemotherapy. The hazard ratio actually was a little bit less than 0.50. Similarly, there was clear improvement in overall survival as well. The hazard ratio was less than 0.6, it was 0.59, and the p-value was strongly statistically significant. And this translates into a 12-month overall survival rate of 52%, which is 20% higher than with chemotherapy at about 29%. So on the basis of these data, the drug has actually obtained a breakthrough and orphan drug designation here in the FDA, and therefore is undergoing expedited review, and it's likely that it will be approved in the next several months as third-line therapy. Similarly, these data have been submitted to Japanese regulatory authorities and will likely be approved there in the relatively not too distant future as well. So the safety profile certainly was consistent with what was previously seen. As you can see, again, hematologic toxicities are the main toxicities associated with this drug. In addition, nearly 10% of patients did experience interstitial lung disease or pneumonitis. The majority of these were grade 1 and 2. There were only 3 that were grade 3 and 4. That translates to a rate of about 2%. Nevertheless, there were no treatment deaths specifically from interstitial lung disease alone. So certainly, I think this argues, that the interstitial lung disease / pneumonitis toxicity is real, and as we get more and more clinical experience, this is absolutely a toxicity that we will have to monitor for and potentially develop comprehensive treatment paradigms for. So on the basis of the initial phase 1b data, the next study that was launched as well is the Destiny Gastric 02 study. So this is a straightforward study in the second line. It is a single-arm study of trastuzumab deruxtecan. The plan is to enroll 72 patients, and patients are being enrolled in the US and Western Europe to try to confirm its activity outside of East Asia. The next drug to talk about is margetuximab. So margetuximab essentially is a trastuzumab molecule that's been enhanced for ADCC, or antibody-dependent cell-mediated cytotoxicity. So you'll see from the cartoon that margetuximab binds to a HER2-positive cell. The modified FC component then attracts immune effector cells, most typically NK cells. The NK cells bind to the FC component and are then able to help lyse the cancer cells. So based on this, margetuximab was tested as monotherapy and has a relatively modest confirmed PR rate of 10%. More recently, it was studied in combination with pembrolizumab, which is an anti-PD-1 antibody, and you'll see significantly more activity. In the waterfall plot on the left, activity was evaluated in patients who were found to have HER2 amplification by cell-free DNA in the peripheral blood, and that was about a 30% response rate. Similarly, in the tumors that were classically HER2 or strongly HER2 positive IHC3+, there was about a 35% response rate. So on the basis of these data, there is a phase 2/3 study known as the Mahogany study that's launched. Another promising drug is ZW25s, and this is a bispecific antibody as well, but one arm essentially is trastuzumab, and the other arm is pertuzumab. So as I had mentioned, I consider Jacob to be a near miss, so in and of itself, there is some rationale to consider this combination again. But more to the point, the bispecific antibody and the specific geometry leads to a unique mechanism of action that is thought to be greater than just combining trastuzumab and pertuzumab alone. Certainly, it was well tolerated in preclinical studies, and in the clinical experience that's been presented so far in phase 1b studies, it also appears to be associated with a single agent response rate in the 40% range, with a duration of response of between 4 to 6 months. Based on this, further studies of this drug are ongoing. Finally, there's significant interest in combining trastuzumab-based therapy with immune checkpoint inhibitors, and this is really based on kind of a positive feedback. It's thought that trastuzumab may enhance immune mechanisms, and at the same time, immunotherapy may actually further enhance the underlying mechanisms of trastuzumab. So on the basis of this, our group and our colleague Yelena Janjigian actually published the following study recently in Lancet Oncology, which combined pembrolizumab with trastuzumab and with a chemotherapy doublet. She reported a response rate in excess of 80% with a 100% disease control rate. The median progression-free survival was 13 months, and median overall survival were 28 months. So on the basis of these very encouraging data, there is actually a phase 3 study, the Keynote 811 study, that's ongoing. This, therefore, is a summary of some late-stage studies that are, as well as phase 2 studies that are ongoing. As mentioned, Keynote 811 is actively recruiting patients, as is the Mahogany study. Integra is a study that's being run out of Germany that's looking at the interesting premise of either FOLFOX with nivolumab and trastuzumab, or actually a chemotherapy-free combination of ipilimumab, the CTLA-4 inhibitor, with nivolumab and trastuzumab. Destiny Gastric 3 is a small phase 1b/2 study that's beginning to combine trastuzumab deruxtecan with chemotherapy combinations, as well as with immune checkpoint inhibitors, specifically durvalumab, which is a PD-L1 inhibitor. As I mentioned, ZW25 is being looked at both in combination with chemotherapy alone, but also in combination with chemotherapy, as well as tislelizumab, which is an anti-PD-1 antibody. And finally, there's another antidrug conjugate, RC48, which I didn't discuss, that's also being evaluated in combination with anti-PD-1 antibodies. So to summarize, technically up to this point, HER2 strategies beyond trastuzumab have unfortunately not been beneficial. However, there are numerous novel and promising strategies that are being evaluated. In particular, trastuzumab deruxtecan has demonstrated clear improvement in outcomes compared to chemotherapy in the third-line setting. And these positive results are likely to translate into regulatory approval in multiple places in the world, and therefore a new treatment option for our patients. Thanks very much, and I'll turn it back to David.
Okay, thanks, Jeff. So that was an excellent overview, I think, of this current status of HER2-targeted therapies and very promising new agents that are moving forward. So I think you can comment a little bit about this, given your recent talk. Do you see a role for antibody-drug conjugates in an earlier treatment setting?
Yeah, I think the answer is absolutely yes. I mean, I think again, the Destiny 02 study clearly showed that it's active in the third-line setting. The Destiny 1 study. Destiny 02 is the study that's being conducted in Western Europe and in the US, and it's looking at it in the second-line context. And I think if we are able to, see and recapitulate the same activity, then I think it likely will move into the second-line setting. Beyond that, I think, of course, that there is interest in looking at it in the first-line palliative setting. And as I had mentioned, it is being looked at in combination with immunotherapy. It's also being looked at in combination with other cytotoxic chemotherapy. I have mixed thoughts about it because its main toxicities, and it is chemotherapy to some degree. So, multi-agent chemotherapy may or may not make the most sense. But certainly beyond that, I think increasingly, we would also be looking to try to move it into earlier stages of disease. Although, the results of RTOG 1010 are sobering, and certainly would suggest that at least trastuzumab and chemoradiation don't necessarily mesh well.
Yeah, and a last question before we move on. How do we manage the interstitial lung disease adverse event associated with trastuzumab deruxtecan?
Yeah, so I think that's probably an area that all of us will unfortunately need. Well, I mean, both fortunately and unfortunately need to develop experience in. As we're participating in the Gastric O2 study here, and we have seen pneumonitis in some of our patients. Certainly, the current guidelines state that if anyone develops grade 2 or more pneumonitis, in other words, changes on CT scan as well as symptoms, the drug has to be discontinued permanently. And even for patients who have grade 1 pneumonitis, which is CT findings but no clinical symptoms, it's unclear what the optimal management is. It's unclear whether they can be retreated. Certainly for patients who are symptomatic, we've been treating them with steroids, but it's also unclear if this is the optimal approach. I mean, I think at this point, as I mentioned, trastuzumab is not known to cause pneumonitis. Topoisomerase inhibitors don't cause pneumonitis. So I think the ultimate, pathogenesis and pathophysiology of it is unclear. Whether it's inflammatory and will respond to steroids, whether it will get better on its own. I think these are questions that really will be answered in the years to come as the drug is FDA approved in breast, it likely will be approved in gastric. There are other rare, HER2 positive cancers that it's being looked at. So I think it will become, an issue for practitioners to be aware of and to have to manage moving forward.
Okay, so again, thanks for an excellent overview. So now we're going to move on to the last part of our discussion today, which is now looking at other novel strategies to treat gastric cancer. How are we going to incorporate some of the new and emerging agents? So we saw this slide earlier in our current sequencing and treatment algorithm. In metastatic gastric cancer, HER2 testing is critical initially. If patients are HER2 positive, we include trastuzumab in combination with chemotherapy. If patients are HER2 negative, then the standard is a platinum fluoropyrimidine doublet, potentially with or without the addition of docetaxel. On disease progression, we now have a standard second-line therapy defined, which is paclitaxel ramucirumab. For a more borderline performance status patient, although we do have the option of ramucirumab alone or single-agent chemotherapy alone, the preferred approach is still the combination of paclitaxel and ramucirumab, given its higher degree of efficacy. And then in the really poor performance status, ECOG 3 or 4 patient, these are patients that we would need to consider transition to supportive care alone. Again, the goal of chemotherapy is palliation and durable efficacy. For each individual patient, we have to assess age, functional status, and comorbidities. And the vast majority of patients should receive combination chemotherapy first line. And doublet combinations, typically a fluorinated pyrimidine and platinum agent, would be the preferred regimen. We would reserve monotherapy agents for the elderly or poor performance status patients. And again, we would add trastuzumab to chemotherapy in HER2-positive gastric cancer. The triplet regimen, either DCF or a modified schedule like FLOT, we really reserve only for younger patients without comorbidities with high functional status. And as I'll discuss in a minute, emerging data suggest little benefit for triplet regimens above 2-drug therapy. I always include this slide in my discussion of chemotherapy in metastatic gastric cancer, really to emphasize if we look across the board at response rates, then time to progression and overall survival, regardless of whether we use a doublet or triplet regimen, there's overlap with response rates of about 35 to 40%, time to progression of 5 to 6 months, and a median overall survival of only 9 to 11 months. Really not indicating any clear-cut benefit for triplet therapy above 2 drugs. And the standard of care has really evolved to a combination of either capecitabine or infusional 5-FU with oxaliplatin, consideration in selected patients for the use of FOLFIRI. I think one of the important trials that really drove this point home was an important Japanese trial, JCOG 1013. This was a large randomized trial of more than 700 patients with metastatic gastric cancer, and this compared triplet chemotherapy. So the doublet was S1, which is an oral fluorinated pyrimidine with cisplatin, S1 cisplatin with or without docetaxel. The primary endpoint was overall survival, and I think it's clear from this slide that there was no significant difference in overall survival for 2 versus 3 drug chemotherapy, and also no difference in response rate. So for the vast majority of patients, a doublet combining a fluorinated pyrimidine and platinum, preferably oxaliplatin, would be the standard of care. VEGF-targeted therapy has a clear role in second-line treatment. The drug ramucirumab, that is a blocking antibody to the VEGF receptor, showed benefit as a single agent in the REGARD phase 3 trial, in which ramucirumab was compared to placebo, best supportive care, and there was a modest improvement in overall survival for ramucirumab over placebo. More clinically relevant is the RAINBOW trial, because this took standard second-line paclitaxel and combined it with ramucirumab, and we saw an improvement of more than 2 months of median overall survival, and also an improvement in both progression-free survival and an improvement in response rate. So paclitaxel ramucirumab is the de facto standard of care in second-line treatment. So what about immunotherapy? Well, getting back to Dr. Tang's points earlier, it is important that we test cancers for MSI and for PD-L1, and possibly as well Epstein-Barr virus. We can see from this waterfall plot that the lion's share of responses to PD-1 targeted therapy in this graph are limited to either EBV positive or MSI high cancers. Another option has emerged in the third line with the randomized trial of trifluridine tipiracil, or TAS-102, versus placebo. This was a randomized phase 3 trial, the TAGS trial, conducted in chemotherapy refractory gastric cancer. And here we can see a modest overall survival benefit of about 2 months for trifluridine tipiracil versus placebo. This was accomplishing mostly disease stabilization. So we really didn't see responses to this drug, but we saw disease stabilization and a modest improvement in progression-free and overall survival. So this is now a third-line option for patients with chemotherapy refractory disease. So what about immunotherapy in esophagogastric cancer? I've listed the key trials here in GE junction and gastric cancers. For single-agent activity, KEYNOTE-59 led to regulatory approval for pembrolizumab in both MSI-high and PD-L1 positive cancers. This was a large expansion cohort in chemorefractory gastric and GE junction cancers. MSI-high cancers had a significant response of 50 to 60%. PD-L1 positive patients had modest benefit with a response in the 12% range. Based on this, pembrolizumab was approved in the chemotherapy refractory setting for either MSI-high or PD-L1 positive gastric cancers. The trial from Japan, ATTRACTION-2, compared nivolumab, another PD-1 inhibitor, versus best supportive care in refractory gastric cancer, and showed a response and survival benefit for nivolumab irrespective of PD-L1 status. The negative trial in late line was the Javelin Gastric 300. This was in third-line treatment comparing physician choice chemotherapy versus avelumab, which is an anti-PD-L1 drug. Avelumab was not superior to physician's choice chemotherapy. What about second-line use of checkpoint inhibitor therapy? KEYNOTE-61 was also a negative trial. This was a comparison of pembrolizumab versus paclitaxel in PD-L1 positive gastric and GE junction adenocarcinomas. The study did not meet its primary endpoint. More importantly, I think, on this study is that the control arm was arguably not appropriate. This should have been paclitaxel ramucirumab, so any comparisons of pembrolizumab to chemotherapy must be taken in the context of this having an inferior control arm, which really should have been paclitaxel ramucirumab. And then lastly, we'll talk about in more detail in a bit, the first-line trials, which unfortunately have also been overall negative for their primary outcomes. KEYNOTE-62 was a first-line trial in PD-L1 positive gastric and GE junction adenocarcinomas, looking at chemotherapy alone, pembrolizumab alone, or a combination of pembrolizumab plus chemotherapy. I'll mention briefly Javelin Gastric 100. This was a maintenance strategy. After receiving upfront chemotherapy, patients would be randomized to continue chemotherapy or maintenance therapy with avelumab. Avelumab was not superior to chemotherapy, so as written, this was a negative trial. So this is the data for KEYNOTE-59. This was the large expansion cohort of 259 patients. And here we can see in the waterfall plot that there was activity for patients. Overall, about a 12% response rate. Responses were really largely seen in the PD-L1 positive patients. Then we have the ATTRACTION study. This is nivolumab versus placebo in third-line treatment of gastric cancer. This was irrespective of PD-L1 status. And here we can see improvements in both overall survival and progression-free survival for nivolumab over placebo, with a near doubling of 1-year survival. There also was an anti-tumor response observed of about 11%. The negative trial in third line was the Javelin Gastric 300. Again, this was avelumab versus physician choice. You can see in the progression-free survival curve that avelumab was actually inferior. More patients progressed more rapidly on avelumab than chemotherapy, but overall survival was equivalent but not superior for avelumab. So KEYNOTE-62 has been a very controversial trial. This is the first-line trial of pembrolizumab in PD-L1 or CPS1 positive patients. Here we look at the outcome for pembrolizumab plus chemotherapy versus chemotherapy alone, and we can see this was a negative result. There was no difference in 1-year median overall survival and a slight separation in the curves at 2 years at 5%. And the hazard ratio was 0.85. So what about pembrolizumab plus chemotherapy in CPS10 patients, higher PD-L1 expressors? A very similar outcome. No clear additive benefit for pembrolizumab added to chemotherapy over chemotherapy alone, with no significant difference in median overall survival, and the hazard ratio is 0.85. Again, we do see a late separation of the curves, which we see consistently in immunotherapy trials, which argues a late benefit for these drugs and does not mandate their earlier line use. So what about a head-to-head comparison of pembrolizumab versus chemotherapy alone? So there's a lot of controversy about this analysis because this was a non-inferiority analysis in a very small number of patients. Most troubling is the fact that in the left side of the curve, actually there were more cancer-related deaths in the first 12 months on pembrolizumab versus chemotherapy. So actually there was a higher fatality rate for patients getting pembrolizumab alone earlier. Then you see that the curves cross, and again there's a late separation of the curve. So even though the hazard ratio is 0.91 for non-inferiority, arguably I think most practitioners would not accept a higher death rate for pembrolizumab in the first 12 months. And again, we know that these agents can have efficacy in later line treatment. This is in the PD-L1 CPS 1% or higher. Now we do get a more robust separation at 12 months in the CPS 10% patients, but again, look at the left side of the curve. There are more cancer-related deaths, as much as 10% to 20% higher in patients getting pembrolizumab first, followed by a crossover to chemotherapy. So again, I'm not sure that we would be willing to risk death from the cancer early on with pembrolizumab to get this later benefit, and again, arguably pembrolizumab could be used later line. But certainly, as we've seen in other studies, the CPS 10 patients may derive a greater benefit from pembrolizumab than the CPS 1% patients. And again, the issue is very rapid progression in the majority of patients getting pembrolizumab alone. If we look at both the CPS 1 and 10 patients, we see a rapid drop-off of patients getting pembrolizumab. More than 50% of patients are progressing on pembrolizumab within the first several months. This is also borne out looking at CPS score as a biomarker of efficacy. This is the second-line trial of pembrolizumab versus paclitaxel, looking at overall survival by PD-L1 CPS status. Early on in this trial, PD-L1 negative patients were accrued, and here we can see a clear survival inferiority for pembrolizumab versus paclitaxel. For the CPS1 patients, again, we see early parity and then a late separation of curves. and then perhaps a more robust separation in the CPS 10 patients, 10% patients. Again, remember that the control arm in this study was paclitaxel, which is inferior. Although these data do suggest that CPS 10 patients may be better candidates for earlier line use of pembrolizumab, this does not change the standard of care, and pembrolizumab should, in most cases, be considered a third-line treatment after progression on paclitaxel and ramucirumab. I'm going to talk briefly about an emerging target, Claudin 18.2. This is a gap junction protein overexpressed in the vast majority of gastric cancers. 70% overexpress this protein. The antibody zolbetuximab is a monoclonal antibody that targets this antigen, and it may potentially stimulate antibody-dependent cellular cytotoxicity. In the FAST trial, this was a randomized phase 2 trial in Claudin 18.2 overexpressing patients, and this was a trial of EOX chemotherapy with or without zolbetuximab. We can see on the left there was a significant survival benefit for zolbetuximab, 13.2 versus 8.4 months for chemotherapy alone, and in the high expressors of Claudin 18.2, a more robust 7-month improvement in survival for this agent. Based on these promising phase 2 data, there are ongoing phase 3 trials of zolbetuximab. The Spotlight trial is looking at FOLFOX plus or minus zolbetuximab in high Claudin 18.2 expressors, and the GLOW trial is looking at capecitabine oxaliplatin plus or minus zolbetuximab in first-line treatment. Then I'm just going to mention a number of ongoing selected trials. These are mostly phase 1 and 2 trials looking at novel combinations of checkpoint inhibitors with other immune agents and PARP inhibitors. The one I'm going to focus on is on the bottom, which is bemarituzumab, which is the phase 3 trial targeting patients with FGFR abnormalities. Remember, this is a common pathway that's affected in esophagogastric cancer. And this is looking at the monoclonal antibody bemarituzumab, which targets the FGFR2 receptor, and the standard arm is chemotherapy alone. So what are the take-home messages looking at trying to incorporate these new agents into advanced gastric cancer? Guidelines now clearly recommend that we test patients for HER2 status, but we also should perform early testing for MSI status and PD-L1 expression. Arguably, for MSI high patients, we might consider earlier line use of checkpoint inhibitors given the high rate of response and often durable remissions seen. For PD-L1, we would reserve use of checkpoint inhibitors at this time largely for third-line treatment in PD-L1 positive patients. Again, as we discussed earlier, there's a renewed interest in novel HER2-targeted therapies with a particular interest in trastuzumab deruxtecan, which is significantly active in the second-line setting in HER2-positive patients with meaningful improvements in response rate, progression-free, and overall survival, which led to regulatory approval for this agent in HER2-positive breast cancer. And although pembrolizumab is approved in the third-line setting, immune checkpoint inhibitors have shown modest activity in earlier settings, particularly the MSI-high patients, where arguably we could consider using it first or second line, perhaps the CPS 10% patients, pembrolizumab second line, and for patients that are 1% or less than 10%, pembrolizumab would be used as a third-line or fourth-line option. We obviously hope for the development of new targets and therapy strategies, which are ongoing and under investigation, to enhance further the treatment of our patients with advanced gastric cancer. So to close our session, I'd like to now move into this case discussion. This actually is one of my own patients. Can we translate the science into improving care and outcomes for our patients? This was a 46-year-old man who presented with anorexia, nausea, pain, and right upper quadrant pain and weight loss. Imaging showed innumerable hepatic metastases, and his endoscopy showed 2 esophageal masses. A liver and the primary biopsy showed adenocarcinoma. Family history did show some other cancers, but past medical history was notable only for asthma. He did have baseline liver dysfunction with a bilirubin of 2 and a serum creatinine of 2, and had massive hepatomegaly on physical exam. This is imaging from the outset. So let's open this up to the panel discussion now. So we have a young patient, very symptomatic, bulky metastatic disease with some organ dysfunction. So what would be our next step? Would we give the ECF regimen, which we actually no longer use epirubicin? Would we give DCF or FLOT or an equivalent? Would we give Folfox or Fulfuri? Would we wait on tissue testing for PD-L1, HER2, or MSI? Or are we too late to treat the patient? So comments from the panel.
Well, so I mean, certainly, I think in a young patient, we absolutely would try palliative chemotherapy. I think by virtue of his bilirubin and his creatinine, I think he would be ineligible for a clinical study. So really, we would be focusing on standard of care options, as you mentioned. Thankfully, we're not using epirubicin-based regimens anymore. So I think, on the table would be Folfox, which I think, certainly in the U.S. and globally is a standard of care. A bilirubin of 2, certainly from my perspective, would make irinotecan not a good option. And similarly, docetaxel, I believe the cutoff, for using it is a bilirubin really of about 1.5. And as you pointed out, I mean, the incremental benefit of adding docetaxel to a frontline doublet is really unclear. So I think outside of a study that he's not eligible for, I would certainly strongly consider Folfox, while at the same time trying to ascertain his HER2 status, but also importantly, MMR status and PD-L1.
Yeah, so although I showed the negative data for the Japanese phase 3 trial, the FLOT regimen did suggest a higher response rate for triplet therapy, and as did the DCF regimen. So I opted to actually start this patient with Folfox initially, which he tolerated well, and I added docetaxel at the second cycle. Gradually, his renal function improved and the hepatomegaly reduced. And we finally got results back from his liver biopsy, which showed that he was IHC 3+ for HER2, and we added trastuzumab starting at cycle 3. We then later received outside genomic profiling, which confirmed HER2 amplification, but then showed some amplification of some other non-targetable areas. So this is consistent with a genomically unstable cancer. So here we can see a rather dramatic radiographic response. This is August and then February, and then a year later, where he's almost achieved a radiographic complete response to treatment with resolution of renal dysfunction as well as the liver function abnormalities. So we stopped the oxaliplatin at 4 to 5 months and continued 5-FU docetaxel. And as I showed, scans were showing a little, if any, residual disease. At that point, we opted to do an endoscopy at 21 months, which showed a long segment of Barrett's esophagus, but no residual primary cancer. So, interesting case now, approaching the second year of treatment. What do we do now? Continue maintenance therapy with infusion of 5-FU docetaxel and trastuzumab. Change to trastuzumab maintenance therapy alone, with or without capecitabine. Would we change to paclitaxel ramucirumab? Would we stop therapy? Would we check for circulating tumor DNA, or would we consider a clinical trial?
I mean, so certainly, I think it certainly wouldn't make sense to change treatment in the context of ongoing response. And again, in the context of ongoing response, he probably wouldn't be eligible for a study, and it would be difficult to justify it. Certainly at this point out, I mean, if someone's been on docetaxel for a year or more, I have occasionally seen patients develop fluid retention, including ascites, which can mimic disease progression, and pleural effusions. So certainly my inclination would be to discontinue that, and for the time being, continue trastuzumab with either infusion of 5-FU or with capecitabine, if that offers some convenience and improvement in quality of life. I think cell-free DNA or circulating tumor DNA is an emerging option. If I were absolutely contemplating stopping chemotherapy, I potentially would check cell-free DNA. We know the mutations that are found in his tumor, and you can try and correlate both. And if truly he has a radiographic and clinical response, and cell-free DNA is also absent, that potentially at some point might be stronger justification for stopping treatment completely, based on the assumption that he is in that rare and fortunate group of patients who can have a prolonged and durable complete response to chemotherapy. So certainly, I'm curious to hear what you selected for him.
Yeah, so I tried to encourage him to stop the docetaxel, but he wanted to continue it. We did change him ultimately to an every 3-week cycle at the 3-year point. Then he had a repeat endoscopy, which continued to only show Barrett's esophagus, and his imaging showed stable 1 or 2 sub-centimeter liver nodules. Now, one issue comes up in the context of our discussion. What if this patient did show progression on HER2-directed therapy? Jeff comments about the next steps if he progressed on treatment.
Yeah, no, I would absolutely agree that if he progressed, I mean, clearly it would be unexpected and really sad. But I absolutely would rebiopsy, especially because there are now, I mean, institutionally we actually have numerous interesting anti-HER2 strategies. So I think as I had mentioned at the beginning, we certainly would use the HER2 status of any progressive or recurrent lesions to guide whether we would go down that route. Or whether we would focus on HER2 negative strategies. But given his very favorable progression-free survival, if he were to eventually progress and he remained HER2 positive, I would consider that a high priority because of the favorable PFS.
Yeah, and we may have a new drug in the offing, depending on the outcome of regulatory approval for trastuzumab deruxtecan.
Right.
Okay, and now that we're in the era of COVID-19 and gastric cancer, I indicate a potential ASCO-sponsored website to help guide us as we make difficult decisions at the time of the pandemic, how best to administer chemotherapy, how best to use combined modality therapy, radiation therapy. These are all issues that are ongoing in the pandemic. Well, I want to thank my speakers today for a really excellent overview of HER2-targeted therapy and novel agents in gastric cancer, as well as the important pathologic assessment early on in patients.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/JQB860. This activity is supported by independent educational grants from AstraZeneca and Daiichi Sankyo Incorporated.